Diabetes ketoacidosis is an acute metabolic complication of diabetes mellitus that is a consequence of absolute insulin deficiency. It is a medical emergency with important complications. Management of diabetic ketoacidosis. Management: clinical features, symptoms and signs. Symptoms: polyuria, thirst, weight loss, weakness, nausea, vomiting, leg cramps, blood vision and abdominal pain. Blood vision and abdominal pain. Signs: dehydration, hypotension, postural or supine hypotension, cold extremities, peripheral cyanosis, tachycardia, air hunger, it means Kussmaul's breathing, smell of acetone, hypothermia and delirium, drowsiness and coma in 10% case. Investigations: blood glucose level, urinalysis for ketones, urea and electrolytes, plasma bicarbonate, arterial blood gas analysis to assess the severity of the acidosis, serum amylase, ECG for evidence of acute MI, hypo or hyperkalemia, chest X-ray, for consolidation and pulmonary edema. Infection screen, whole blood count or CBC, blood and urine culture, C-reactive protein, COVID-19 swab if at risk, then pregnancy test in all women of childbearing age. Treatment of diabetic ketoacidosis. Principal components of treatments are correction of dehydration, correction of glucose level, administration of short acting or soluble insulin, correction of electrolyte imbalance, potassium replacement and additional measures. Correction of dehydration, intravenous fluid replacement. If systolic BP, dehydration if systolic BP less than 90 millimeter of mercury, fluid bolus 500 milli normal saline, 500 milli normal saline over 10 to 15 minutes. If systolic BP less than 90 millimeter of mercury, if systolic BP is still less than 90 millimeter of mercury, repeat fluid bolus plus senior help. If systolic BP greater than 90 millimeter of mercury, 1 liter. Normal saline over 1 hour. Then 1 liter saline over 2 hours. Then 1 liter saline over 2 hours. Then 1 liter normal saline over 4 hours. Accurate fluid balance and aim to urine output. Aim for urine output greater or equal 0.5 milli per kg per hour. A more cautious approach is advised in young adults, in pregnancy, in older adults, and those with a history of kidney or heart failure. At 10% glucose, at 10% glucose, 125 milli per hour, when glucose level less than 14 millimole per liter. Administration of insulin. Correction of blood glucose level, administration of short-acting or soluble insulin. Correction of glucose level by 0.1 unit per kg body weight per hour in IV infusion by infusion pump. Continue subcutaneous basal insulin analog if normally taken. The fixed rate insulin infusion should be continued until diabetes ketoacidosis has resolved. Defined as blood ketone 0.6 millimole per liter bicarbonate. The fixed rate insulin infusion should be continued until diabetic ketoacidosis has resolved. It is defined as blood ketone less than 0.6 millimole per liter bicarbonate greater than 15 millimole per liter and venous pH greater than 7.3. Potassium level correction or correction of electrolyte balance, mainly potassium level greater than 5.5 millimole per liter. No need of potassium supplementation. Potassium level 3.5 to 5.5, 40 millimole potassium to be added in per liter infusion. Potassium level less than 3.5, add 40 millimole per liter potassium chloride. Next, senior help if not responding. Additional measures: IV broad spectrum antibiotic if infection is present, catheterization if no urine passed after 3 hours, central venous line or CV line if cardiovascular system compromised, measure arterial blood gas and repeat chest X-ray if oxygen saturation less than 92%. ECG monitoring in severe case, thromboprophylaxis with low molecular weight heparin. Thromboprophylaxis with low molecular weight heparin. Hypoglycemia in diabetic patient. Hypoglycemia and hypoglycemic coma. Hypoglycemia causes and risk factors of hypoglycemia. এটা দেখি শুনতে আসতে হবে ভাইদের থেকে, এটা নিয়ে অনেক বিতর্ক, দুই কথাই শুনি যে তিনটাই লিখতে হবে, আবার কেউ বলে ট্রিটমেন্ট লিখলে হবে। হ্যাঁ, causes and risk factors of hypoglycemia in diabetes mellitus. Number 1, insulin excess insulin, erroneous injection of insulin, dose miscalculation or injection of incorrect insulin. Then deliberate overdose, bariatric surgery can cause hyperinsulinemia. Increased sensitivity to insulin, increase sensitivity to insulin, exercise, weight loss, sudden reduction in glucocorticoids, unrecognized Addison's disease. Reduced carbohydrate intake or increased metabolic demand. Irregular or missed meal, gastroparesis due to autonomic neuropathy causing variable carbohydrate absorption, bariatric surgery, malabsorption, examples in celiac disease, eating disorder, early pregnancy and breastfeeding. Decreased carbohydrate. 4. Decreased gluconeogenesis, and or glycogen reserves in alcohol, chronic kidney disease, advanced liver disease. Number 5. Increased glucose variability, absent or minimal endogenous insulin secretion, reduced C-peptide, long duration type 1 diabetes, insulin treated type 2 diabetes, young age of onset of type 1 diabetes. Then number 6, reduced ability to detect hypoglycemia. Impaired awareness of hypoglycemia, rapid improvement in and or strict high glycemic control, previous severe hypoglycemia, long duration type 1 diabetes, or duration of insulin treated type 2 diabetes, older age, dementia, sleep, no or inadequate glucose monitoring. Management of hypoglycemia. Management of hypoglycemia, clinical features of hypoglycemia, investigations and treatment. Clinical features: autonomic, neuroglycopenic and non-specific. Autonomic includes sweating and trembling. Then profound heart, hunger, anxiety. Neuroglycopenic, delirium, drowsiness, speech difficulty, inability to concentrate, incoordination and irritability. Non-specific, nausea, tiredness and headache. Investigations: blood glucose, urine analysis for ketones, urea electrolyte, plasma bicarbonate, arterial blood gas, to assess the severity of acidosis, ECG for hypo or hyperkalemia, infection screen, full blood count, blood and urine culture, C-reactive protein and chest X-ray. Now treatment. Mild hypoglycemia, level 1 and 2 self-treated, mild and severe. Level 3 mild on hypoglycemia, treated with oral refined fast-acting carbohydrate. 10 to 15 gram. Glucose drink or tablets or confectionery. Once glucose level is greater than 4 millimole per liter, take additional long-acting carbohydrate of choice. See here, if patient is conscious, unable to swallow, but confused, disoriented or aggressive. Conscious, unconscious. Patient is conscious and able to swallow but confused, disoriented or aggressive. Give 2 tubes of 40% glucose gel squeezed into the mouth between teeth and gums. Repeat blood glucose measurements after 10 to 15 minutes, and if ineffective after 3 cycles, call doctor and consider intramuscular glucagon. IM glucagon 1 milligram or IV 10% glucose. If patient is unconscious, feeding or very aggressive or nil by mouth, parenteral treatment is required. IV 75 milli. 20% dextrose. IV 150 milli. 10% dextrose for 15 minutes. Intramuscular glucagon 1 milligram. Intramuscular glucagon 1 milligram. Causes of unconsciousness in a diabetic patient. Causes of unconsciousness in diabetic patients: hypoglycemia, diabetic ketoacidosis, non-ketotic hyperosmolar coma, and other causes of unconsciousness, infection and other metabolic causes. Difference between hypoglycemic coma and diabetic ketoacidosis. Difference between hypoglycemic coma and diabetic ketoacidosis. History: hypoglycemic coma, missed meal, vigorous exercise, insulin overdose. In case of diabetes mellitus, missed insulin overdose, and here missed insulin. Sweating present, absent. Dehydration absent, present in diabetic ketoacidosis. Pulse, bounding pulse, high volume, bounding pulse, low volume pulse. BP normal, low. Now features of shock, abdominal pain, blurring of vision, acetone breath, Kussmaul breathing, all are absent in hypoglycemic coma but present in diabetic ketoacidosis.